Okay, so in this video, we're going to talk about respiratory alkalosis, and this is typically going to occur in an acute exacerbation, and the pH is going to rise rapidly in a response to a rapid drop in the PCO2 or in the carbon dioxide that's in our blood. So let's first just take a look at where we start at homeostasis. So in this respiratory alkalosis model, we're going to start with homeostasis being within the normal pH of 7.35 to 7.45, when the respiratory disturbance is going to cause this hyperventilation, which is causing the body to get rid of CO2. This could be from anxiety-induced hyperventilation, or it could be a mechanical ventilation, like a patient on a ventilator that is being overventilated. The pH is going to correspond by increasing because the amount of CO2 that's in the blood is going to decrease, which is going to decrease the body's ability to make that carbonic acid, which means that we've got more base than we have acid, so our pH is going to rise above that 7.45. Our buffering systems are going to kick in. The buffering system will begin to make available any of this extra hydrogen. So it's going to release hydrogen to counteract that deficit. The renal system will excrete bicarb in the urine, and it will generate those hydrogen to be released in the blood. And this is because we're trying to increase the amount of acidity that is available in the blood, because that ratio of bicarb to acid is off. So the respiratory center can also be stimulated, especially if we don't have any type of lung disease going on and there's another issue going on. It's actually going to send a message to the brain, and it will decrease the respirations and the depth, and that's because this is going to help lower the pH, because we're going to start holding on to that CO2, and it's going to work to actually correct that pH and bring it back to normal. And hopefully we make it back to this homeostasis of a normal pH of 7.35 to 7.45. So with respiratory alkalosis, it's always going to be caused by some sort of hyperventilation. And this is going to cause that carbon dioxide to be in a deficit. Hypoxemia, which is just simply low oxygen in the blood, can signal the brain to increase our respirations, and this can cause an overventilation or hyperventilation. This can be in a response to pain. It could be in response to fear, anxiety. The patient could even have a fever and sepsis, or maybe encephalitis, or even a brain injury. And as the body's respirations increase, the amount of CO2 blown off is also going to increase. And there's little CO2 left in the blood to actually make that carbonic acid. And so this results in a higher pH, which is going to be higher than that 7.45, but it also means that when we take that PaCO2, it's going to be less than 35 because everything's been blown off. It's not holding on to it. Now, if our bodies continue in this alkalotic state, compensation is going to start to begin. And remember, it can take that renal system hours to days to actually compensate. And a lot of times, respiratory alkalosis is an acute reason that our patient may be in this respiratory alkalosis. So it sometimes can be corrected before compensation actually takes place. But in the event that compensation does not occur before the renal system kicks in, the renal system will kick in and it will begin to get rid of bicarbonate. And this is in order to reestablish that 1 to 20 carbonic to bicarb ratio. So that got out of whack when we were blowing off too much of that carbon dioxide because we couldn't make carbonic acid. So a faster compensation is going to try to occur on the cellular level. And this is where chloride and bicarb will actually shift. Chloride will come out of a cell and bicarb will be shifted into a cell. And then another cellular component that a nurse needs to be aware of is that of alkalosis and calcium. Calcium will begin to bind to albumin, which is going to result in hypocalcemia that's going to cause that neuromuscular excitability and some of those signs and symptoms that are present with hypocalcemia. So remember vasoconstriction, you've got the Shavatsky's and Trousseau's signs. And this vasoconstriction can also occur from a decreased level of cerebrovessels, which are resulting in that lightheadedness feeling or difficulty concentrating and even dizziness. So how are we going to diagnose this? We're going to look at our ABGs. So we talked about a few of the signs and symptoms just a second ago, but mainly we're going to focus on our ABGs. And if we have a pH that is greater than 7.45, we know that we are alkalotic. If our PCO2 is less than 35, then we know it's a respiratory problem. So we have respiratory alkalosis. And when we look at our bicarb usually has not changed at this point. It's going to be normal because the kidneys have not had time to actually compensate. So we're going to be within that 22 to 26 normal range. Now, after assessing our ABGs, there's going to be some other key things that we're going to look at that are going to point to what we need to address. And this is going to include our respiratory rate. We expect that the respirations are going to be high and shallow at first. And this is because the patient is going to be exhaling more than they're inhaling. They're going to be blowing off that CO2, and they're also going to become hypoxic because low O2 is going to result from those respirations. We need to be checking their vitals. They may have a fever, and if that's the underlying physiological cause, then we need to continue to assess that fever and treat that fever so that we can help bring that down and hopefully reverse that alkalosis. Also, we need to gather some information about what may be leading up to a circumstance. So if it is anxiety that is causing this patient to have an episode of hyperventilation, then we kind of need to know what caused that anxiety. What were the leading circumstances that brought this on? Because that's going to help the nurse actually help the patient on the psychological level to be able to reverse this hyperventilation, because anxiety is much more of a psychological with a physiological presence. So that can help the nurse knowing that what was going on surrounding when this episode started. And this can help the nurse to be able to reassure the patient maybe that they're not having a heart attack, because some of those manifestations and some of the ways they may feel, especially from anxiety, can produce those tight chest or those palpitations just like a heart attack can. But our patient needs to understand they're not having a heart attack, it's an anxiety attack. So knowing the circumstances surrounding an episode can actually really help this. And that's why it is so important that we gather that information, we get that history, and we figure out what all is going on with that patient. How are we going to treat that? Our treatment is going to focus on the underlying cause or correcting the imbalance. So if the imbalance is from an electrolyte, we're going to try to correct that electrolyte. If it is because of an underlying cause, we're going to look at those causes. So like I just said, some of the causes could be psychological and are going to require the nurse to treat the patient with some psychological help, which basically means that we're going to have to encourage them to slow breathe. We're going to have to reassure them that what is going on is anxiety and it is not an underlying physiological problem. Now, there are causes that are physiological, like I stated earlier, if the patient has a fever, so we would treat the fever. If it is hypoxia or low oxygen, then we're going to treat by giving some oxygen. And the nurse is going to have to adjust or treat whichever of those physiological processes is going on. If it's an electrolyte imbalance, they're going to have to treat that electrolyte imbalance. So Any of these causes is what we're going to focus our treatment on. So let's go back to anxiety for a minute. If anxiety was the cause of respiratory alkalosis and it's due to hyperventilation, we're going to have the patient focus and we're going to try to help them slow their breathing. And this is that psychological thing. They can mentally slow their breathing down. Now, in some cases, we do have to give them a rebreather or a bag to breathe in, and what this is going to do is they're going to be rebreathing that CO2 that they've blown off, and this is going to help increase that CO2, and it also will help them slow down because they are a little bit more focused. But say your patient is being mechanically ventilated. The settings can simply just be adjusted. Maybe we need to decrease the tidal volume, which means the amount of air that we are blowing in to blow off. Or maybe the rate is too high for this patient. So this can cause some alkalosis. So adjusting that and adjusting the ventilator settings can actually help us make sure that the patient's not blowing off too much CO2. Now, because of hyperventilation, our patients are also at risk for the loss of consciousness. Now, in anxiety type patients, I'm not talking about ventilated patients, but in anxiety or fever or those types of things, a lot of times what can happen is if they lose consciousness, their body will actually kick in and they will return back to normal ventilation. So, but we need to make sure that we are preventing any type of injury, because if they become unconscious, they could fall, they could get hurt in some other way. So if they were to pass out, remember their respirations will automatically return to normal because of that psychological stimulus is removed, and hopefully that will return that acid-base balance back into normal. But we do need to prevent injury in this case. Now, let's review all of that real quick. So, in review of respiratory alkalosis, remember that the pH is going to be high, 7.45 or greater, and this is because there's not a lot of acid in the blood. The PCO2 is going to be low, and this is because we've blown off all of that CO2 and we've decreased the amount that was available to make the carbonic acid. Bicarb will be within normal range, 22 to 26, because the kidneys are going to take a long time to actually start compensating. Now, in the event that it continues and compensation does begin to occur, then our bicarb is going to start to drop because the kidneys are getting rid of that bicarb to help bring that ratio of bicarb and carbonic acid back into balance. So what we will see also is just like the PaCO2 has dropped and the bicarb has dropped, that's what's going to bring that ratio back into a normal range, and our pH will go back into a normal range of 7.35 to 7.45. So remember that partial compensation can also occur as well when the body is working to correct this alkalosis, but the pH is not going to be quite back to normal, and we'll still see that drop in PCO2, as well as we could see that drop in the bicarb as well, but our range of pH may just be barely above that 7.45, which means that we're trending in that compensated way, but we've not completed that compensation. So it's not a complete, it's just a partial compensation. And that could be because the kidneys still need just a little bit longer to actually create that compensation. So if you think about Rome, we've got respiratory is opposite. So if you look back up, I'm just going to hit on this again. Your pH is high, so the opposite of that, because it's respiratory, is going to be that our PCO2 is low. So in respiratory opposite, the pH is high, the PCO2 is low. So they are in opposition of one another. All right, we'll work some examples of this in our Blackboard Live. So if you have any questions, make sure you write those down so I can get those answered in that as well.